Starting with the name of Almighty Allah, I welcome you all to my channel Tab Shakhtar Live. So today our topic is anesthetic management of ischemic heart disease. So I have spent a generous amount of time understanding the topic, making the notes so that you can understand it better. So let's get started. First, let's understand what the term ischemic heart disease means. Then later on we are going to talk how we are going to manage this, right? So first, ischemic heart disease is a condition in which the blood flow to the heart muscle called the myocardium. These vessels that supply the blood to the heart muscle are called the coronary arteries. These vessels get narrowed and the flow is also restricted. So ischemic heart disease is an umbrella term that includes three conditions. What it includes? It includes mainly angina pectoris and myocardial infarction. In angina pectoris, there is severe chest pain that is caused because of the narrowed arteries that results in the reduced supply. So there is an imbalance in the oxygen demand and supply. As a result, there is an ischemia, but there is no permanent tissue damage. It is reversible, right? But in case of myocardial infarction, what happens? What is the pathophysiology? So there is a complete blockage of the blood vessel, coronary artery, usually because of the thrombus, right? It results in the death of the myocardium, the necrosis of the tissue, right? And this condition is severe, right? As this results in the death of the tissue, so it requires an immediate medical intervention, right? Moreover, I said there are three conditions that are included in the IHD. The other thing is what we call the coronary artery disease. I know you might be thinking that sometimes we use IHD interchangeably with CAD, but ischemia is an umbrella term. Both in ischemia and CAD, it signifies that there is a reduced lumen of the artery, but CAD is a condition that a structural condition, the narrowing of the artery that leads to the ischemia, right? So now let's talk about how we are going to assess the first step in this process is the assessing the patient, right? In what terms we are going to assess how this functional reserve is, like what is the capacity of the heart, how tolerant it is. So we will use a rule called the 4 METs, right? It is the single best predictor of the peri-operative outcome, right? So here comes another term, peri-operative outcome. So peri-operative, what does peri-operative mean? So peri-operative means the time around the surgery. It includes pre, during, intraoperative and the post-operative period of the surgery. Right, so that's the peri-operative. Now talking about the METs, that is metabolic equivalents. So here we are going to talk about the pre-operative assessment, right before the surgery, right? So MET, that is metabolic equivalents, is a unit of oxygen consumption. So if a person performs a certain activity that requires MET more than 4 and he is capable of doing it perfectly, right? Like walking a flight of stairs or walking uphill. So and he doesn't feel a bit like he doesn't feel breathlessness, he doesn't get fatigue at all, like, right? So he is having a good reserve, he is having a good functional reserve, right? So we will grade him as more than 4, he is having more than 4 METs, metabolic equivalents, right? And a person which will get tired after such activities, he will feel breathlessness, so we will say that he has a poor reserve, right? Less than 4 METs, right? He cannot perform daily activities, and he will have a more higher risk of peri-operative outcome, right? And moreover, in these situations, we will look for other things like what are the cause of this poor reserve, right? Now let's move ahead and talk about how we are going to stratify the risk. There is a system for this called the RCRI, Least Revised Cardiac Risk Index. Based on this scoring, we will categorize or grade the patient as per the risk. That will determine how likely the patient is having the chances of getting a cardiac event, right? Cardiac events such as MI. So first, there are six predictors. There are six factors that we will look for, and each factor carries 1 point. So if the patient has undergone high risk surgery, whether abdominal, chest surgery, or vascular surgery, right? So we will give him 1 point for that. And if the person has ischemic heart disease, we will give him +1 for that. And if he is having congestive heart failure, we will give him more 1 point, right? Similarly, for cerebrovascular disease, stroke, transient ischemic attack, or mini stroke, or if the person is having diabetes, insulin dependent diabetes mellitus, right? And finally, we will also do the blood test to determine the pre-operative serum creatinine. If that is more than 2 mg per deciliter, we will give him more point. More the higher score means higher the probability of cardiac events, right? Now let's move ahead and talk about investigations we have to make. We'll do the routine investigations like the 12 lead ECG to look for the electrical activities of the heart, and we'll do the chest x-ray to see the structure and function of the lungs as well as heart, right? And in the lab test, we'll see the complete blood count, potassium levels, creatinine levels to determine the kidney functions. Other than this, we will perform special investigations based on the functional status of the person. We will perform Holter monitor for detecting the arrhythmias, right? In which a device is placed that shows the ECG of 24 hours of the patient. Other than this, we'll do stress echo that measures the electrical activity during exercise, and we will perform dobutamine stress echo. If the patient is unable to exercise, we'll perform coronary angiography. We'll use dye and X-ray to determine the vessel structure. Apart from this, we will also optimize the drug. So now talking about the beta blockers, the person can continue the beta blockers. They should not be allowed to skip the dose as it can cause tachycardia. And if the beta blockers is advised by the doctor, it should be started 1 week period to the surgery. Antiplatelets like aspirin can be continued, but clopidogrel should be stopped 5 days prior, and prasugrel stopped 7 days prior. And ACE inhibitor and ARBs, angiotensin receptor blockers, should be withheld 24 hours pre-operative, as they can cause refractory hypotension, that is vasoplegia, under anesthesia. If the patient has gone under surgical intervention such as a balloon angioplasty, right, that is done to open the narrowed lumen, right, we will wait for 14 days before surgery. And in case of bare metal stent, we will wait for 30 days. If the person had a previous episode of MI, heart attack, and no stent, we will wait for 3 months. And similarly, in case of ABG, coronary artery bypass grafting, and in case of drug-eluting stents, DES, will wait for 6 months. So why is this waiting? So why do we wait for in case of these surgical procedures, right? So because otherwise the stent can cause what? Thrombosis. There can be clot formation in these stents. So we wait. And then if we talk about the DES considerations, that is the drug-eluting stent considerations, we can perform the surgery 3 months per year if surgical delay risk is more than the thrombosis risk. And in case of coronary artery bypass grafting, right, that is bypass surgery, we can wait for 3 months. We have to wait for 3 months for sternal healing, so that the breastbone or the sternum gets properly healed, right? Now let's talk about the our role during intraoperative. Like, we have to look for the supply and demand, right? We'll make sure that the demand remains less, and we will avoid decreasing oxygen supply by hypotension, anemia and hypoxia, and tachycardia. As you can see, tachycardia is also here and also here. So what I mean to say, it can simultaneously reduce supply and increase demand. Now let's talk about the monitoring. So we have to perform ECG with the leads L2 and lead V5. Lead L2 is best for detecting arrhythmias with the help of P wave, right? And lead V5 is best for detecting left ventricular ischemia, and both can be used in 95% of the cases to detect ischemia. Other than this, we can use invasive monitoring like arterial line for beat to beat blood pressure monitoring. Apart from this, we can do transesophageal echo, in which device probe is placed inside the esophagus, which is more sensitive than the invasive monitoring, and provides us wall motion abnormality and is better as it precedes the ECG changes. But limitation is that it is invasive, right? And for the induction, we can use etomidate as it is cardiostable. It maintains blood pressure and cardiac output. We can use also propofol, but we have to avoid hypotension. Contraindication: we cannot use ketamine as it causes sympathetic stimulation. It can cause tachycardia, increase in the heart rate, hypertension, increase in the blood pressure. Right? As a result, it can precipitate. It can stimulate myocardial infarction, heart attack. Right? Now let's talk about the blunting the sympathetic surge. So at the time of intubation, there is a risk of intubation response. So that will cause tachycardia, hypertension. This is a peak risk moment for ischemia. So the strategy should be to blunt the reflex before instrumentation. So we will use lignocaine IV that will suppress airway reflexes. Fentanyl opioids block stress response. High dose, we will use high dose. Right, esmolol, short acting beta blocker to cap heart rate. Right, and we will use sevoflurane, and we will avoid desflurane, right, as it will cause tachycardia. And in high risk patients with poor left ventricular function, these gases, volatile agents, can cause myocardial depression. So we will, in those patients, we will maintain the anesthesia using a high dose of opioid like fentanyl, right? And we will not use nitrous oxide as it causes mild sympathetic stimulation, increase in the pulmonary vascular resistance. Now let's talk about the neuromuscular blockade or heart-safe choices. So we will use vicuronium and ricuronium, and we will avoid pancuronium. Vicuronium and ricuronium are cardiac stable. So we will use these muscle relaxants, and we will avoid pancuronium as it will cause tachycardia. And to reverse the effect of neuromuscular blockers, we will use reversal agents like neostigmine and glycopyrrolate. We will not use atropine as the reversal agent as it causes tachycardia and significantly increasing oxygen demand. Glycopyrrolate is slower onset and gentler on heart rate. Right? Now, let's talk about the danger zone, that is post-operative care. So after the surgery is done, the risk is not over. After 48 hours, that is 2 days, there is a higher chances of MI, that is heart attack, right? So we need to manage the triggers like the pain that causes tachycardia, right? So we'll provide adequate analgesia, aggressive analgesia, and we'll make sure that the patient does not shiver as it increases oxygen demand by 400%, and treat with warmers and pethidine. And for hemodynamic stability, we will use these drugs for hypertension, NTG, tachycardia, esmolol, beta blockers, hypotension, we use inotropers and vasopressors. Now, final takeaways, the anesthetic mandate, right? What we studied so far, we are going to quickly recapitulate that with this summary checklist. First, we talked about the pre-op, right? We'll assess the capacity with METs, right? And optimize meds. Like we will tell the patient, you can keep taking beta blockers, right? And intraoperatively, we will prevent tachycardia. We will balance the supply and demand. Drugs we can use etomidate for induction and avoid ketamine, atropine, and pancuronium. And post-operative, we will watch for 48 hours closely. Treat shivering aggressively. That's it all for today. Thank you. That's all for today. I hope you learned something new today, and you can subscribe to my channel for more such videos and share your views in the comment. You can also visit my website Tabish Akhtar Live to access these notes.